Are they visible now?
Yes, yes.
Okay. So, good morning, everyone. We are starting this great conference today, the second day, with a discussion on insulins. And this is what I am going to talk in the next few minutes is introduce the Insulin Co formulation that we all have been using and its clinical attributes beyond efficacy. And this is my disclosure. Of course, this is a Novo Nordisk sponsored session. But what we are going to discuss is the science. So, when it comes to managing our patients with diabetes, I think there are a number of challenges that all of us identify. Poor glycemic control, of course, is the one challenge which actually propels us towards thinking for insulin because data clearly shows that almost 76.6% of adults with type 2 diabetes in India achieve that golden target of HbA1c less than 7%, out of which 83% have suboptimal postprandial control. So, a very important challenge why our patients are not achieving a good HbA1c is also the poor PPG control that is seen in Asian Indian populations. And I'll come to that in a little while. Now, in spite of all the studies showing that patients are not under control, the HbA1c is not on target, there's a very important challenge that all of us need to identify and take steps to prevent it is therapeutic inertia, which means that in spite of knowing that patient needs insulin, we do not start insulin on time. And studies show that 10% of adults with type 2 diabetes in India actually achieve an injectable treatment after spending 10 years of diabetes, and most chunk of it is uncontrolled diabetes. Now, non-adherence to therapy is again a very important challenge because multiple complex regimes, cost factors, so many other factors clearly show that almost more than 50% of Indians are non-adherent to their anti-diabetic therapy. And hypoglycemia is again a huge barrier to glycemic control because one episode of severe hypoglycemia actually leads to cessation or downregulation of treatment, and therefore patient is not able to achieve a good glycemic control. So whenever we talk of treating a patient with type 2 diabetes, these are 5 important key challenges we need to keep in our mind. Now, what do we expect from an insulin therapy? We need a holistic insulin therapy that is going to be efficacious, safe, and it has to give good glycemic control, but at a cost of no hypoglycemia. So you need an insulin therapy which gives lower hypoglycemia compared to the others. It offers mealtime flexibility, so it can be dosed according to the highest meal of the day. The regime of insulin that we prescribe to our patients has to be simple because complex regimes sometimes are too difficult for patients to understand and follow. And then there are a lot of prescription errors that happen when you put them on complex regimes. Convenience of the device is also something very important because the moment we say insulin, patients have the needle phobia, patients feel it is going to be very painful. So a good device which is painless is something which is more acceptable to the patients. Eventually, a good efficacious insulin regime, which is simple to follow, offering flexibility, reduced hypoglycemia, translates into better glycemic control and a better quality of life for our patients, and eventually turns out to be cost effective in terms of reduced complications in the future. So, with these kind of characteristics, what we need to see is whether the co-formulation of IDEC Aspart fits this entire bill of choosing the best insulin for our patients. Now, just to give a very brief introduction of the world's only co-formulation insulin, the IDEC Aspart insulin that all of us have been using, we all know this is basically 30% the Aspart hexamers and about 70% the ultra long acting degludec hexamers that are fitted together in solution, coexisting peacefully with each other, both in solution and in the subcutaneous tissue. So it's more like a marriage of convenience wherein both the insulins coexist peacefully and then they retain their individual properties. So the rapid acting continues working as a rapid acting without interference from the degludec or the ultra long acting. And the degludec provides a constant basal control without interference from the Aspart. So you have a marriage of convenience of a rapid acting insulin with an ultra long insulin in the same injection. So both of them peacefully coexisting and going on their own paths parallel to each other while still staying together. Now, how does it work? You can clearly see here the basal ultra long acting degludec provides a flat and stable control all day for the 24 hours, while the mealtime control, the postprandial control with the biggest meal of the day, is provided by insulin S part. So, when you dose it with the biggest meal of the day, you will take care of the post meal spike that happens with that meal, as well as the long term ultra long acting degludec is going to provide the basal component with a flat and stable glycemic control. So this is backed by a number of clinical trials, and you can see on your screens the phase 3A and the phase 3B trials, where it has been used with all the different patterns and different patients, and has been compared and proved to be as good as and even superior to detamir insulin, to Bias 30, to Glargine U100, as well as the basal plus and the basal bolus regimes. Now, this is a huge amount of real world evidence that backs the efficacy and safety of IDEG-Part, and you can see coming from all over the world, including data from our own Indian stalwarts. Now, when it comes to the efficacy of this co-formulation, let me show you this beautiful study wherein about 296 insulin-naive patients, one arm was initiated on IDEG-Part one shot along with OADs, and the other arm was given the basal insulin Glargine U100, which we use as a standard along with OADs, and these were followed up for 26 weeks. What you see on your screens is a similar fasting control with 70% basal component in the IDEG-Part versus the 100% basal in Glargine U100. But you see a much superior HbA1c reduction of 1.4% versus the basal alone. And probably this is attributed to the better postprandial control that you see after the major meal, almost a 57 milligram reduction in the postprandial glucose levels. So IDEG-Part provides a superior long-term glycemic control compared to the Glargine U100 with a similar degree of fasting reduction, even when the basal component is only 70% in the IDEG-Part. Now, this is the ARISE India results. Again, 185 adults with type 2 diabetes prescribed IDEG-Part as per the local practice. And you can see 43.8% patients were given once daily injection of S-Part with the biggest meal of the day. And 56.2% patients were given twice daily S-Part. So you can clearly see that the end of study, you see a mean reduction in HbA1c of 1.6%. And similarly, like I said, even a reduction in fasting plasma glucose by almost 52.2 milligrams. So clearly you see that the ARISE India data shows that in Indian patients, you see a significant fasting reduction along with an HbA1c reduction when you use a co-formulation of IDEG-Part. Now, if you look at the safety data, again, like I said, hypoglycemia is a huge challenge. So the moment you talk of insulin, besides the fear of injections, hypoglycemia appears as a huge challenge. After a severe episode of hypoglycemia, studies have shown that almost 84.2% of patients experience a fear of future episodes. Even after a mild or moderate episode of hypoglycemia, 30% patients experience a fear of future episodes of hypoglycemia, and therefore 16.2% of patients actually start skipping their anti-diabetic medications. And again, due to the fear of future hypoglycemia, because one hypoglycemia scares them so much, 36.7% will report reducing their insulin doses, and even 11.7% actually start missing their insulin injections. So therefore, hypoglycemia is a huge challenge. Now, how does IDEG-Part fare when it comes to the hypoglycemia concern? Well, this is the ARISE global cohort clearly showing you that the number of hypoglycemic episodes, both non-severe as well as severe, come down drastically when you initiate a patient on IDEG-Part compared to patients who are not given IDEG-Part. So you can clearly see 4 weeks prior to initiation versus 4 weeks after initiation, you see a significant reduction in the number of severe as well as non-severe hypoglycemic episodes with IDEG-Part. So clearly the number of hypoglycemia comes down. This is the SMART study, again documenting what I said before initiation of IDEG-Part versus 2 weeks, the 3 months, 6 months, and the 12 months post IDEG-Part, you will see much less episodes of confirmed hypoglycemia and zero episodes of severe hypoglycemia with idegespart. So we're seeing how it is meeting all the challenges. Now moving on to how simple is it to initiate and dose idegespart. Well, if you have a patient failing on OADs and you initiate him on a basal insulin, what happens is, suppose his glucose levels are not under control, the postprandials are not on target, then you have to add an additional spart injection with the biggest meal, and then maybe still you need to upstep by adding a second spart and eventually a third spart. So eventually a patient goes on to 4 shots, which means three boluses and 1 basal. So that is the intensification that we follow when you start a basal and then you go to basal plus and eventually result in a basal bolus with 4 shots. Compared to that, when you initiate a patient on 1 shot of idegespart, and then you can very easily intensify by adding the second shot with the second biggest meal, and you eventually get similar HbA1c reduction, and patient is able to achieve goal HbA1c target along with goal fasting and postprandial targets by simply starting on 1 shot and intensifying with the second shot. Now, this is data that I'm going to show you on a comparison between idegespart versus the basal bolus therapy. So you are, as you can see here, this was about 500 plus patients with type 2 diabetes who were already uncontrolled on a basal insulin. So what was done? One arm was switched from basal to idegespart along with OADs, 1 shot, and the other arm was continued on basal with OADs and 1 shot of spart was introduced. So this is 2 shots of idegespart plus 1 shot of idegespart plus OADs in 1 arm, and glargine plus spart, that means 2 shots, a basal plus regime along with OADs in the second arm. So beyond 26 weeks, if they were still not on target, what was done was intensification. That means a second shot of idegespart was added to OADs in patients who were not on control, not on target, with 1 shot of idegespart in the first arm. And in the second arm, where patient was already on a basal plus, he was further intensified by adding a second shot or even a third shot of spart. So in the second treatment period, that is 26 weeks to up to end of treatment 38 weeks, we have intensified by putting 2 shots of idegespart with OAD in 1 arm and basal bolus regime in the second arm. But surprisingly, what we see is idegespart achieved similar improvements in fasting plasma glucose as well as HbA1c compared to the basal bolus. So there you are giving 4 injections. Here you are giving 2 pricks, but you are achieving similar fasting control and similar HbA1c control. And what you also see is a 9% significantly reduced dose of insulin being required in the idegespart arm, and the fewer mean number of daily injections, obviously, because here the intensification was 2 injections of idegespart. In the other arm, you are seeing 4 injections with basal bolus. So the number of injections is less, total dose of insulin required is less, but the degree of glycemic control achieved is same. So it is easy to switch to idegespart from other insulin regimes. So if your patient is already on a basal 1 shot or a premix 1 shot, you can transform and switch him to idegespart 1 shot or maybe intensify to twice. Similarly, a patient who is not doing well on a basal or basal plus or a premix twice, 2 shots, he can be switched to idegespart 2 shots. And somebody on a basal bolus, based on the individualized parameters, you can switch him to 2 shots of idegespart. And of course, friends, it is very important that glucose monitoring is done when we are doing the switch, because you need to individualize therapy based on the careful consideration of the basal bolus therapies, because this is a very insulin regime, intensive insulin regime, and close glucose monitoring, like I said, is important. Now, how does all this translate to an improvement in the quality of life? You can clearly see here that the total dose of insulin required and the basal insulin dose requirement comes down, as you can see here. Besides that, in this study, you can clearly see that the diabetes therapy related quality of life improves because the patient is able to achieve good glycemic control with lesser insulin doses, lesser number of pricks, and he's happier. So the quality of life and the complications are also much prevented. So the treatment preference, of course, 7 out of 10 patients, that means almost 75% patients, prefer idegespart to their previous treatment. So therefore, lesser insulin requirement, lesser dose requirement, and significant improvement in quality of life. This is a single standard study from Dr. Coville's center. Again, adults were questioned. They were switched to Idegespart, and they were given a questionnaire of 26 questions to actually look at their quality of life improvement and treatment preference. And what this showed was 95% patients were happy, managed their day-to-day activities better after Idegespart initiation. Almost 90% had improved quality of life because the number of pricks came down, and almost 86.7% patients found it comfortable to inject Idegespart in different social situations. So all of this tells you that the quality of life is good and the pill burden comes down, because once you are able to achieve a good glycemic control, so patients who were on 3 OADs can be shifted to 1 or 2 OADs, and 50% of 2 OADs a day were shifted to 1 OAD. So maybe an Idegespart injection with one meal and the OAD on the second meal. So the pill burden also comes down with improved quality of life and adherence to treatment. So dosing convenience and flexibility is a hallmark of this insulin. And the best part is you can give this insulin with the largest meal of the day. So if your patient is somebody who has a heavy breakfast and is a light eater for lunch or dinner, you can give this shot in the morning. Somebody who eats a heavy dinner, so you can space it at night. So you can initiate with 10 units of Idegespart with the major meal of the day, with the, where the carb content of the meal is heavy. And then suppose the glycemic control is still not achieved, so you are still seeing a post-meal spike with some other meal, you can add, that means you can intensify by adding a second shot of Idegespart with the second carb-heavy meal of the day. So meal size and the postprandial response should dictate the ratio of the two doses. It's not necessary that you're giving exactly the same units in the morning and the same units with the second meal. So whichever meal is the heaviest, you give a bigger dose at that time. Whichever meal is lighter than the heaviest meal, so the second dose can be a little less units for that meal. So it is not necessary that you have to equally divide the dose between the two shots. So a practical recommendation of how you should actually titrate the doses is based on a very simple algorithm. You look at the fasting plasma glucose. If your patient is taking Idegespart once with whichever major meal of the day, just look at the fasting plasma glucose. If it is on target, you maintain the same dose. If the fasting plasma glucose is still above that individualized target for the patient, you increase in steps of 2 every week till you achieve a fasting plasma glucose on target. If the patient is experiencing hypoglycemia or the fasting plasma glucose is less than the target, you reduce 2 units. However, if the patient is on 2 injections of Idegespart with 2 major meals of the day, then if the patient is you look at the pre-breakfast or the pre-lunch, that dose, if you're suppose giving the injection in the morning or you are giving it with lunch, then you have to look at the pre-dinner blood glucose level. So the pre-dinner blood glucose level will dictate either the morning or the lunch dose if the patient is taking it at that time. The second dose, so if the patient is actually going to take the shot for dinner time, so the pre-dinner dose will depend on the pre-breakfast dose. So you look at the fasting glucose level to decide on the pre-dinner dose, and you look at the pre-dinner glucose level to decide on the breakfast or the lunch dose. I hope I've made that clear. If the patient is taking one shot of Idegespart with whichever meal of the day, just look at the fasting and keep up titrating or down titrating. If the patient is taking a dose at dinner, pre-dinner, so you look at the fasting glucose and accordingly up titrate. If the patient is taking a pre-breakfast shot or a pre-lunch shot as the second shot, then you look at the pre-dinner glucose level and then you up titrate or down titrate. Now, a lot of people feel that this is an expensive insulin because if you look at the cost of the cartridge or the cost of the pen, you find it expensive. But this is a study that actually, an Indian study that looked at the cost effectiveness in terms of exactly the yearly total cost of medication and healthcare resources based on the Indian cohort. What this showed is if you look at the medication price, yes, seems to be a little more expensive than the other medications put together. But if you look at the overall aggregate of the healthcare resources utilized, the outpatient visits, the emergency room visits, the inpatient hospitalizations, and the work days missed, If the patient is not on glucose control, or if he lands up with an acute or chronic complication and needs all that treatment, what you discover is the yearly total cost is lower with idegespart, because you achieve a better degree of glycemic control, and therefore the risk of complications, hypoglycemias, hospital administrations, emergency visits all comes down. So it actually proves to be a cost effective in the long term. So friends, to wind up, idegespart is a choice when you have to initiate an insulin, because all the challenges that I talked of are met with this insulin. It is an efficacious insulin. It is a cost-effective insulin which provides you a good quality of glycemic control and offers the benefits of mealtime flexibility, lower hypoglycemia, a simple regime which can be initiated and then intensified, convenience of the device. The device is very beautiful, and a better quality of life in the end. With that, I'll rest my case and I'll hand over to the organizers.